Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. Today, our focus takes us deep into the realm of thrombocytopenia. Firstly, bleeding disorders and platelet abnormalities manifest through bleeding into the skin or mucous membranes, known as mucocutaneous bleeding. Common symptoms include petechiae, purpura, ecchymosis, epistaxis, and gingival bleeding. While similar findings occur in vascular disorders, they are relatively rare. Deep tissue bleeding, such as hematoma and hemarthrosis, is associated with clotting factor deficiencies. If you're ready to uncover the mysteries of thrombocytopenia, go ahead and hit that like button, and let's dive right in. Now, let's focus on thrombocytopenia, characterized by a decrease in circulating platelets. The reference range is 150,000 to 450,000 per milliliter. Thrombocytopenia, with a platelet count less than 100,000 per milliliter, is the most common cause of clinically significant bleeding. It's crucial to differentiate true thrombocytopenia from artifacts caused by platelet clumping or satellitosis. The primary pathophysiologic processes include decreased platelet production, accelerated platelet destruction, and abnormal platelet distribution. Manifestations of thrombocytopenia include small vessel bleeding in the skin and hemorrhages of varying sizes, petechiae, 1 mm, purpura, 3 mm, and ecchymosis, greater than or equal to 1 cm. Remember, ecchymosis corresponds to a bruise. Other factors contributing to the hemorrhagic state include defective platelet function, vascular fragility, and trauma. It's interesting to note that clinical bleeding doesn't always closely correlate with the platelet count. Bleeding is unusual when the platelet count is above 50,000 per milliliter, but the risk of clinical bleeding increases as the count drops below 50,000 per milliliter. Patients with counts below 10,000 per milliliter are at high risk for serious hemorrhagic episodes. Now, let's explore impaired or decreased platelet production. Abnormalities are categorized into megakaryocyte hypoplasia and ineffective thrombopoiesis. Inherited thrombocytopenia is linked to specific chromosomal abnormalities or genetic defects. Conditions like Fanconi anemia, TAR syndrome, Wiskett-Aldrich syndrome, Bernard-Soulier syndrome, and Meheglin anomaly exhibit a lack of adequate bone marrow megakaryocytes. Thrombocytopenia in Bernard-Soulier syndrome and Wiskett-Aldrich syndrome is primarily due to qualitative defects. Meheglin anomaly. It's a rare autosomal dominant disorder with an unknown frequency. Patients exhibit large platelets, 20 mm, and dough-like bodies in neutrophils. While platelet morphology, aside from size, is normal, thrombocytopenia occurs in 1/3 to 1/2 of patients. Surprisingly, platelet function is generally normal. Some patients may show increased and structurally abnormal megakaryocytes. Mutations in the MYH9 gene, responsible for the non-muscle myosin heavy chain, are reported, potentially causing abnormal platelet size. Most patients are asymptomatic unless severe thrombocytopenia is present, and some may have prolonged bleeding times without complications. Now, let's explore other disorders linked to MYH9 gene mutations. Sebastian syndrome, an autosomal dominant condition, presents with large platelets, thrombocytopenia, and granulocytic inclusions. Fechner syndrome exhibits similar abnormalities alongside deafness, cataracts, and nephritis. Epstein syndrome showcases large platelets with additional complications like deafness, ocular problems, and glomerular nephritis. Moving on to TR syndrome, a rare autosomal recessive disorder. It's characterized by severe neonatal thrombocytopenia and the congenital absence or hypoplasia of radial bones. This condition is associated with RBM8A gene mutations or a 200 kilobits deletion involving the RBM8A gene. TAR syndrome brings bony abnormalities, cardiac lesions, and a high incidence of transient leukemoid reactions. Platelet counts usually range from 10,000 to 30,000 per milliliter in infancy, increasing over time. Let's discuss Fanconi anemia, associated with thrombocytopenia. This condition entails extensive abnormalities, including bony and visceral organ abnormalities, and pancytopenia. Next up is congenital megakaryocytic thrombocytopenia, an autosomal recessive disorder indicating bone marrow failure. Infants with this disorder have platelet counts below 20,000 per milliliter at birth, leading to bleeding and anomalies. Half of the infants develop aplastic anemia in the first year, with potential myelodysplasia and leukemia later. The curative treatment for this condition is allogeneic stem cell transplantation. It's caused by MPL gene mutations on chromosome 1, leading to thrombopoietin receptor function loss. Finally, let's touch upon autosomal dominant thrombocytopenia, mapped to ANKRD26 gene mutations on chromosome 10. These mutations cause incomplete megakaryocyte differentiation and resulting thrombocytopenia. Interestingly, bleeding is usually absent or mild, and platelet function is typically normal. ANKRD26 mutations are found in 10% of inherited thrombocytopenias, considered relatively frequent. X-linked thrombocytopenia, resulting from mutations in the WAS gene or GATA1 gene on the X chromosome. The range varies from mild thrombocytopenia with small platelets to macrothrombocytopenia with severe bleeding. Now, let's explore a spectrum of other inherited thrombocytopenias. These are due to gene mutations, including HOXA11, ABCG5, ABCG8, FLNA, RUNX1, ITGA2B, ITGB3, TUB1, and CYCS. Various mutations lead to distinct thrombocytopenic conditions. Shifting gears to neonatal thrombocytopenia, where the platelet count is less than 150,000 per milliliter in 1% to 5% of infants at birth. Causes include infections like toxoplasma, rubella, CMV, herpes, and HIV, as well as exposure to certain drugs, particularly chlorothiazide diuretics and tolbutamide, among other factors. Torch infections, especially CMV, are common infectious causes affecting about 1 in 1,000 infants with significant thrombocytopenia. Reports suggest CMV inhibits megakaryocytes, leading to impaired platelet production. Congenital toxoplasmosis and rubella syndrome also contribute to neonatal thrombocytopenia. Maternal HIV transmission and the maternal ingestion of certain drugs like chlorothiazide diuretics and tolbutamide directly affect fetal marrow megakaryocytes, leading to severe thrombocytopenia. Fortunately, recovery usually occurs within a few weeks after birth. Now, let's uncover the underlying causes of neonatal thrombocytopenia. Impaired production, often seen in preterm neonates born after pregnancies with complications like placental insufficiency and/or fetal hypoxia. Increased platelet consumption or sequestration is another mechanism, with causes including transplacental passage of maternal antibodies, disseminated intravascular coagulation, DIC, and other factors. Acquired, drug-induced, hypoplasia, a condition where certain drugs can impact bone marrow function and lead to thrombocytopenia. Let's explore some key insights. Chemotherapeutic agents used for hematologic and non-hematologic malignancies can suppress bone marrow megakaryocyte production and other hematopoietic cells. Examples include methotrexate, busulfan, cytosine arabinoside, cyclophosphamide, and cisplatin, often limiting chemotherapy dosage due to drug-induced thrombocytopenia. Recombinant interleukin-11 is approved for treating chemotherapy-induced thrombocytopenia, and thrombopoietin may offer benefits. Zidovudine, used in HIV treatment, can cause myelotoxicity in severe thrombocytopenia. Specific drugs like anagrelide prove useful for thrombocytosis in essential thrombocythemia and other myeloproliferative disorders. Long-term ethanol ingestion may result in persistent severe thrombocytopenia, potentially due to ethanol inhibiting megakaryocytopoiesis. Interferon therapy commonly induces mild to moderate thrombocytopenia, with severe cases reported under certain circumstances. Interferon A and interferon G inhibit stem cell differentiation and proliferation in the bone marrow, causing thrombocytopenia, though the exact mechanism is unclear. Large doses of estrogen or estrogenic drugs like diethylstilbestrol can lead to thrombocytopenia by suppressing megakaryocytes. Additionally, certain antibacterial agents, e.g., chloramphenicol, tranquilizers, and anticonvulsants are associated with thrombocytopenia due to bone marrow suppression. Now, let's shift our focus to ineffective thrombopoiesis. Megaloblastic anemias, including pernicious anemia, folic acid deficiency, and vitamin B12 deficiency, commonly exhibit thrombocytopenia. Impaired DNA synthesis leads to abnormal megakaryocytes and large platelets with decreased survival time. Vitamin replacement typically yields a response within 1 to 2 weeks, resolving the mild thrombocytopenia. So, understanding the impact of drugs and addressing underlying causes is crucial in managing acquired hypoplasia-related thrombocytopenia. Let's explore some miscellaneous conditions that can lead to thrombocytopenia. Viruses are known culprits, inducing thrombocytopenia by affecting megakaryocytes or circulating platelets directly. The live measles vaccine, for instance, may cause degenerative changes in megakaryocytes, leading to thrombocytopenia. Some viruses interact with platelets via specific receptors, and those linked to thrombocytopenia include CMV, varicella-zoster virus, rubella virus, Epstein-Barr virus, and the Thai hemorrhagic fever virus. Certain bacterial infections, often toxin-related or involving direct interactions with platelets, are also associated with thrombocytopenia. In childhood, many cases of thrombocytopenia result from infections, even without thrombocytopenia, due to vascular damage. Unexplained thrombocytopenia may occur when malignant cells infiltrate the bone marrow, replacing normal elements and decreasing megakaryocytes. Inhibitors of thrombopoiesis produced by abnormal cells contribute to thrombocytopenia in conditions like myeloma, lymphoma, metastatic cancer, and myelofibrosis. Now, let's delve into increased platelet destruction. Thrombocytopenia stemming from heightened platelet destruction can be categorized into two types: destruction triggered by immunologic responses and destruction caused by mechanical damage or consumption. Regardless of the process, maintaining a normal platelet count requires increased production. Thrombocytopenia occurs when production capacity can no longer compensate for the escalated destruction rate. Understanding these mechanisms is crucial for effective management. Now we're delving into the immune mechanisms of platelet destruction, focusing on immune, idiopathic, thrombocytopenic purpura, or ITP. The term idiopathic has been replaced with immune ITP due to our evolving understanding that acute and chronic ITP are immunologically mediated. Let's start with acute ITP, which predominantly affects children but can occasionally occur in adults. It's characterized by sudden onset bruising, petechiae, and sometimes mucosal bleeding in previously healthy children. The primary hematologic feature is thrombocytopenia, often emerging 1 to 3 weeks post-infection, typically viral in the upper respiratory or gastrointestinal tract. The incidence is estimated at 4 in 100,000 children, peaking between ages 2 and 5, with no gender preference. In 10 to 15% of cases initially diagnosed as acute ITP, thrombocytopenia persists for 6 months or more, leading to reclassification as chronic ITP. There seems to be a link between acute ITP and viral illnesses, indicating the production of antibodies and immune complexes against viral antigens, potentially causing platelet destruction. Diagnosis in severely thrombocytopenic children can often be made without a bone marrow examination. Key indicators include recent onset bleeding symptoms, normal complete blood count results, and a lack of family history of bleeding disorders. Mild cases may only present with scattered petechiae, but in most cases, patients develop extensive petechiae, ecchymosis, and may experience hematuria or epistaxis. Severe cases, constituting 3 to 4% of acute ITP, manifest with generalized purpura, often accompanied by various bleeding symptoms. Patients with severe disease are at a 25 to 50% risk of intracranial hemorrhage, contributing to a 1 to 2% overall mortality rate. Most patients recover, with or without treatment, in about 3 weeks, however, some may take up to 6 months for recovery. Recurrent episodes may occur in a few children after complete recovery. While most patients with acute ITP have mild symptoms not requiring treatment, severe cases may benefit from interventions such as intravenous immunoglobulin, IVIG, platelet transfusions, or splenectomy, or a combination of these. Chronic immune thrombocytopenic purpura, or chronic ITP. This condition can affect individuals of any age, but most cases are observed in those between 20 and 50 years old. Females are more commonly affected, with a ratio of 2 to 1 to 3 to 1, and the highest incidence occurs in women aged 20 to 40 years. The annual incidence of chronic ITP ranges from 3.2 to 6.6 cases per 100,000. Chronic ITP typically starts gradually, with variable and sometimes normal platelet counts over periods. Common symptoms include mucocutaneous bleeding, with menorrhagia, recurrent epistaxis, and easy bruising, ecchymosis, being predominant. Immunologic processes drive platelet destruction in chronic ITP, where antibodies attach to platelets, leading to their removal by spleen-based reticuloendothelial cells. Autoantibodies recognizing platelet surface glycoproteins are present in 50% to 60% of ITP patients. Megakaryocytes, expressing targeted glycoproteins, become evident as primary antibody targets, impairing platelet production. Platelet turnover studies indicate a shortened lifespan, reducing from the normal 7 to 10 days to a few hours, correlating with the degree of thrombocytopenia. Peripheral blood abnormalities are platelet-related, with counts usually ranging between 30,000 per milliliter and 80,000 per milliliter. Patients experience periods of remission and exacerbation, leading to platelet counts fluctuating from near normal to below 20,000 per milliliters. Morphologically, platelets appear normal but larger in diameter, reflected in an increased mean platelet volume. Marrow characteristics include megakaryocytic hyperplasia, featuring enlarged megakaryocytes with a single nucleus, smooth contour, and diminished cytoplasm. In the absence of bleeding, infection, or other underlying disorders, erythrocyte and leukocyte precursors maintain normal numbers and morphology. Coagulation tests dependent on platelet function may show abnormal results, and while platelet-associated IgG levels are often increased, there is no conclusive evidence that any method of testing for platelet antibodies is highly sensitive or specific for ITP. Now, let's talk about the initial treatment of chronic immune thrombocytopenic purpura, ITP. The approach depends on the urgency to increase platelet count. ITP patients with platelet counts over 30,000 per milliliter, without additional risk factors, typically have mortality rates similar to the general population and may not require treatment. For patients with risk factors, maintaining a platelet count of 50,000 per milliliter or higher is recommended based on the clinical scenario. In urgent cases, intravenous immunoglobulin, IVIG, remains the preferred treatment. Prednisone is the primary initial treatment for most patients, yielding a response in 70% to 90% with increased platelet counts and reduced hemorrhagic episodes. Approximately 50% of patients benefit in the long term from corticosteroid treatment. In cases of inadequate response to corticosteroids, additional options include IVIG, anti-D immunoglobulin, and, for non-responders, intravenous rituximab. Rituximab typically shows responses within 3 to 4 weeks. If needed, splenectomy may be considered, eliminating the primary site of platelet removal but also removing autoantibody-producing lymphocytes. Splenectomy is effective, with 88% of adult chronic ITP patients showing improvement, and 66% achieving a complete and lasting response. Vaccination with certain vaccines is recommended at least 2 weeks before surgery. Laparoscopic surgery is generally preferred over open splenectomy for its faster recovery and shorter hospitalization. In severe refractory cases, immunosuppressive agents like azathioprine, alone or with steroids, may be necessary. Platelet transfusions may provide transient benefit for severe hemorrhagic episodes but are not recommended routinely. Chronic ITP associated with HIV infection, hemophilia, or pregnancy poses unique challenges in diagnosis and therapy. Unexplained thrombocytopenia in healthy individuals from high-risk populations may signal early signs of acquired immune deficiency syndrome, AIDS. Let's unravel the distinctions between acute and chronic immune thrombocytopenic purpura, commonly known as ITP. Understanding these differences is crucial for effective management. Firstly, acute ITP. It's most common in children aged 2 to 9 and young adults, often following viral infections or immunization, such as measles, chickenpox, mumps, or smallpox. It's usually self-limited, with 80% to 90% experiencing spontaneous remissions lasting days to months. Symptoms include the sudden onset of petechial hemorrhages, purpura, and bleeding from gums or the gastrointestinal or urinary tract. Severe cases may even exhibit hemorrhagic bully in the oral mucosa. Now, let's talk about chronic ITP. It occurs in patients of all ages, predominantly in adults aged 20 to 50 years, and is more common in women. Unlike acute ITP, it usually lacks a clear preceding infection. Chronic ITP is characterized by a fluctuating course, with episodes of bleeding lasting days or weeks. Spontaneous remissions are infrequent and incomplete. Symptoms often begin with scattered petechiae or minor bleeding, and sometimes bruising, menorrhagia, or recurrent epistaxis precedes diagnosis. Platelet counts in chronic ITP range from 50,000 per milliliter to 75,000 per milliliter, generally higher than in acute ITP. Giant platelets are common, and there are elevated platelet-associated immunoglobulin levels, although lacking sensitivity in specificity. Now, let's explore treatment approaches. In acute ITP, treatment is generally contraindicated for non-severely thrombocytopenic and non-hemorrhagic cases. When necessary, IVIG or corticosteroids or a combination usually yield good responses. Splenectomy is rarely needed. For chronic ITP, initial therapy often involves glucocorticoids, increasing platelet survival time by affecting splenic and hepatic macrophages. If corticosteroids are ineffective or intolerable, splenectomy may be considered. Different clinical courses and responses to treatment characterize acute and chronic ITP. We're delving into the intriguing world of immunologic drug-induced thrombocytopenia. Stay tuned as we explore different mechanisms and antibody interactions with both drugs and platelets, and don't forget to subscribe. Let's start with drug-induced immune-mediated thrombocytopenia, a condition differentiated based on antibody interaction with both the drug and platelets. A classic mechanism is seen in quinidine and quinine-induced thrombocytopenia. The antibody interacts with platelets only in the presence of the specific drug. This typically arises 1 to 2 weeks after exposure to a new drug. Many drugs can induce such antibodies, with quinine, quinidine, and sulfonamide derivatives being more common culprits. Pregnant women affected may pose risks for both the mother and the fetus. Quinine, once used in labor facilitation, is no longer employed for this purpose. Initial studies suggested that innocent bystander hypothesis, but a clearer understanding reveals antibodies bind to platelets through their Fab regions, specifically targeting membrane constituents like GPIB/9/V or GPIIB/3A complexes, only in the presence of the drug. The mechanism of how the drug promotes binding without covalently linking to the target or antibody remains to be determined. The Fc portion of immunoglobulin is not involved in platelet binding, allowing it to interact with Fc receptors on phagocytic cells, potentially contributing to the rapid onset and severity of thrombocytopenia. Most drug-induced platelet antibodies are of the IgG class. In rare instances, IgM antibodies are involved. Antiplatelet/antithrombotic agents like abciximab, tirofiban, and eptifibatide exhibit a similar pattern, causing thrombocytopenia within hours of exposure. Next we have hapten-induced antibodies. Some drug molecules are too small to trigger an immune response on their own but can act as haptens. These haptens combine with larger carrier molecules, often forming a complex that acts as a complete antigen. Penicillin and penicillin derivatives are primary culprits causing severe drug-induced thrombocytopenia through this mechanism. The initial platelet count may drop significantly, even below 10,000 per milliliter. The onset of severe and rapid bleeding, with prominent hemorrhagic bully in the mouth, is characteristic. Now, let's explore drug-induced autoantibodies. Drugs stimulate the formation of autoantibodies that bind to specific platelet membrane glycoproteins independently of free drug presence. Examples include gold salts, procainamide, and levodopa. The treatment involves identifying and immediately discontinuing the offending drug. Substitute with another suitable therapeutic agent. Identifying the causative agent can be challenging, often involving a trial and error process. Platelet transfusions may be required for life-threatening bleeds, and high-dose IVIG is generally effective. Now, let's delve into immune complex-induced thrombocytopenia, specifically heparin-induced thrombocytopenia or HIT. Heparin binds to platelet factor 4, PF4, leading to a conformational change and exposure of neoepitopes, triggering an immune response. The Fab portion of the immunoglobulin binds to an exposed neoepitope, leaving the Fc portion free to bind with platelet FcG2 receptor, causing platelet activation. While HIT may result in a less severe decline in platelet count, there's a potential for in vivo platelet aggregation and thrombosis. Treatment involves discontinuing heparin and replacing it with another suitable anticoagulant. Importantly, low molecular weight heparin should not be used as a replacement, as the antibody cross-reacts with it and PF4, leading to platelet activation and aggregation. Then we're unraveling the mysteries of heparin-induced thrombocytopenia, or HIT. Let's dive into the incidence, risks, and immediate actions required when dealing with this condition. HIT is a relatively common side effect of administering unfractionated heparin, occurring in about 1% to 5% of patients. Despite its frequency, there are crucial aspects to understand about its impact on patients. Surprisingly, despite thrombocytopenia, patients with HIT are not typically at significant risk of bleeding since the platelet count usually remains above 40,000 per milliliter. However, there are other complications to be aware of. Thrombotic complications can affect 10% to 30% of HIT patients, emphasizing the need for caution and prompt action upon diagnosis. Let's explore why immediate action is crucial. Heparin administration should be promptly stopped upon HIT diagnosis due to potential severe consequences. Continued heparin therapy can lead to substantial morbidity and mortality, including conditions like gangrene, amputation, and even death. After stopping heparin, the platelet count starts to increase, usually returning to normal within a few days. However, recognizing the signs of HIT is essential to ensure timely intervention. Clinical signs of HIT, involving the immune system, typically manifest 7 to 14 days after initiating heparin therapy. If the patient had prior exposure to heparin, symptoms may appear within 1 to 3 days. Daily measurement of platelet counts is recommended for patients receiving unfractionated heparin therapy, given the potential rapid decline. Let's delve into another warning sign, heparin resistance. Some patients may exhibit heparin resistance, where increasing heparin doses are needed to maintain anticoagulation. This resistance often precedes thrombocytopenia, signaling a need for close monitoring. Now, let's distinguish between type 1 and type 2 HIT. Type 1 involves a rapid decrease in platelet count, but it is mild and transient. Platelet count quickly returns to pre-heparin levels, even with continued heparin therapy. However, we must pay close attention to type 2 HIT. The mechanism of type 2 HIT, although not fully understood, may relate to the known proaggregatory effects of heparin. Short-chain heparin polysaccharides and derivatives like fondaparinux have lower affinity to PF4, making them less likely to cause type 2 HIT. The detection of HIT relies on laboratory testing, but it comes with its own set of challenges, primarily in the form of sensitivity issues. Let's dive into the common methods employed for detection. One common method is the platelet aggregation technique. This involves adding patient serum to platelet-rich plasma, introducing heparin, and monitoring platelet aggregation. While it boasts high specificity, near 100%, its sensitivity is relatively low, around 50%. Sensitivity improvement requires meticulous attention to details. Another method is the serotonin release assay, regarded as the gold standard for HIT detection. It utilizes the platelet property of rapidly absorbing and storing serotonin. Normal platelets, when activated by heparin-dependent antiplatelet antibodies, release stored serotonin. However, SRA has its drawbacks, primarily the need for radiolabeled serotonin. The drawbacks of SRA, such as the need for radiolabeled serotonin, limit its widespread use. But let's explore further considerations, especially for patients on aspirin therapy. Aspirin's effectiveness in preventing cardiovascular events complicates finding suitable blood donors for platelet tests. Patients on aspirin therapy may exhibit less abrupt platelet count drops and lower risks of thrombotic complications. A method similar to SRA is the platelet aggregometry test. It also uses platelet aggregometry but encounters the same challenges related to aspirin therapy. In conclusion, despite the challenges, diligent attention to testing details in the platelet aggregation procedure can yield reasonable sensitivity. The SRA remains highly reliable, albeit constrained by the need for radiolabeled serotonin. Understanding these nuances is crucial for accurate hit detection. Most clinical labs have bid farewell to isotopic methods due to their complexities. Specialized centers now handle hit tests, mainly because of methodological similarities with platelet aggregation and the need for platelets from drug-free donors. Enter enzyme-linked immunosorbent assays, or ELISAs, a game-changer in hit detection. ELISAs have gained popularity by targeting the PF4 heparin complex. Here's how it works: PF4 and heparin are coated on microplate wells, and patient serum or plasma is added. Positive antibody presence leads to color development, a clear indicator of hit. ELISAs offer higher sensitivity than platelet aggregation, comparable to the gold standard SRA, however, they come with lower specificity than SRA or platelet aggregation. It's crucial to note that positive results may not always signify clinical hit, as non-pathologic antibodies can be detected. In cases of type 2 hit, immediate withdrawal of heparin therapy is essential. However, discontinuation without substituting a suitable anticoagulant significantly increases the risk of thrombotic events. It's a delicate balance. In the past, suitable heparin alternatives were limited. But now, we have options. Direct thrombin inhibitors like argatroban and bivalirudin have become viable alternatives. Fondaparinux, although off-label, is gaining acceptance as a second-line agent to manage suspected hit, aiming to prevent acute hit progression. Neonatal alloimmune thrombocytopenia, or NAIT. NAIT occurs when the mother lacks a specific platelet antigen, typically HPA-1a, inherited by the fetus from the father. Fetal platelet antigens can enter the maternal circulation as early as the 14th week of gestation, triggering antibody production and leading to thrombocytopenia in the fetus. Common platelet antigens include HPA-1a, GP3A of GPIIB/3A complex, HPA-5b, BRA, and HPA-3A, BACA, in Asians. The incidence is 1 in 1,000 to 2,000 newborns, with a higher risk in subsequent pregnancies. About 25% of affected neonates face intracranial hemorrhage or death, with half occurring in utero during the second trimester. Neonates may seem normal initially but soon show scattered petechiae and purpuric hemorrhages. Diagnosis involves excluding other causes, considering maternal ITP, and maternal drug ingestion. Confirmation involves platelet typing of both parents and testing for maternal antibodies against paternal platelets. Fetal genotypes can be determined early, and in high suspicion cases, testing or treating the fetus may be necessary to prevent intracranial hemorrhage. Maternal IVIG infusions effectively increase fetal platelet count, and washed maternal platelets may be infused into the fetus if needed. High-dose corticosteroids for the mother are not recommended due to potential fetal toxicity. Post-delivery, transfusion of antigen-negative platelets, usually maternal, and IVIG can be used alone or in combination. IVIG alone is not recommended for bleeding infants, as the response typically takes 1 to 3 days. We're shedding light on neonatal autoimmune thrombocytopenia, or NAIT. NAIT diagnosis requires a prior diagnosis of ITP or systemic lupus erythematosus in the mother. It results from the passive transfer of antibodies from a mother with ITP or lupus to the neonate, making the neonate an unintentional target of the maternal autoimmune response. During pregnancy, relapse is common in women with ITP in remission, attributed to increased reticuloendothelial phagocytosis facilitated by high estrogen levels. Chronic ITP often develops in pregnant women, with remission typically occurring after delivery. Corticosteroids are the primary treatment for pregnant women with ITP, with a low incidence of adverse fetal effects. Neonatal autoimmune thrombocytopenia occurs in about 10% of infants born to mothers with autoimmune thrombocytopenia. Intracranial hemorrhage, a severe complication, is rare, happening in 1% or less of cases. The recommendation against cesarean section delivery for high-risk infants is now in place to avoid unnecessary trauma. Affected newborns may exhibit normal to decreased platelet counts at birth, progressively decreasing for about a week before starting to rise. Neonatal thrombocytopenia typically lasts 1 to 2 weeks but can persist for several months, often not necessitating treatment. Severe cases usually respond rapidly to IVIG treatment. Immediate intervention, including platelet transfusion, IVIG treatment, or corticosteroid therapy, is recommended if hemorrhagic symptoms develop in the infant. We're delving into the rare disorder known as post-transfusion purpura, or PTP. PTP is a rare disorder that typically emerges a week after platelet-containing blood product transfusion, such as plasma, whole blood, or RBCs. It presents with rapid, severe thrombocytopenia and potentially life-threatening bleeding. The recipient's plasma develops alloantibodies targeting platelet antigens from the transfused blood product. More than 90% of cases involve antibodies against the HPA-1a antigen, and PLA2 and other GPIIB/3a epitopes are also targeted. Involvement of other alloantigens like HPA-3a, BOC, HPA-4, PEN, and HPA-5b, BR, has been reported. PTP primarily affects multiparous middle-aged women or those with a history of blood transfusions. It's exceedingly rare in men without transfusions and women with no history of pregnancy or transfusion. The disorder appears to require prior exposure to foreign platelet antigens and behaves like an anamnestic immune response. No clinical trials due to low case numbers. Untreated PTP can have mortality rates approaching 10%. Untreated or unresponsive cases exhibit a prolonged clinical course, with thrombocytopenia lasting up to 4 months. Previous treatments included plasmapheresis and exchange transfusion with some success. However, the current treatment of choice is intravenous immunoglobulin, IVIG, showing efficacy within the first 2 to 3 days. A 2-day course of IVIG is often sufficient, though a second course may be needed occasionally. IVIG is easier to administer with higher response rates compared to plasmapheresis or exchange transfusion. Corticosteroid therapy, while not particularly effective alone, may complement other more effective treatments. Secondary thrombocytopenia presumed to be immune-mediated and touch upon thrombocytopenia in pregnancy, including incidental thrombocytopenia and conditions like preeclampsia. Severe thrombocytopenia can be observed in patients using biologic response modifiers like interferons, colony-stimulating factors, and interleukin-2. The thrombocytopenia linked to these substances is reversible and possibly immune-mediated, supported by elevated platelet-associated IgG levels, especially with interferon use. Immune thrombocytopenia develops in 5 to 10% of chronic lymphocytic leukemia, CLL, patients and a smaller percentage with other lymphoproliferative disorders. Systemic lupus erythematosus presents thrombocytopenia in 14 to 26% of patients, mirroring the clinical picture of idiopathic thrombocytopenic purpura, ITP. Parasitic infections, particularly malaria, are known to induce thrombocytopenia. Let's explore non-immune mechanisms of platelet destruction and delve into thrombocytopenia during pregnancy and hypertensive disorders. Non-immune platelet destruction can occur through exposure to non-endothelial surfaces, activation of the coagulation process, or endovascular injury without depleting coagulation factors. A common cause affecting about 5% of pregnant women, incidental thrombocytopenia manifests as mild thrombocytopenia, 100,000 to 150,000 per milliliter, in approximately 5% of pregnancies. Interestingly, these women are generally healthy, with no history of prior thrombocytopenia. Moving on to hypertensive disorders, about 20% of pregnancy-related thrombocytopenia cases are linked to conditions like preeclampsia, eclampsia, chronic hypertension, and gestational hypertension. Preeclampsia, occurring in approximately 5% of pregnancies around 20 weeks of gestation, is characterized by hypertension, proteinuria, and various symptoms like abdominal pain, headache, blurred vision, or mental function disturbances. Thrombocytopenia is observed in 15 to 20% of preeclampsia cases, and a significant 40 to 50% of these may progress to eclampsia, marked by hypertension, proteinuria, and seizures. HELLP syndrome, a severe complication, involves microangiopathic hemolysis, elevated liver enzymes, and low platelet count. It complicates 4 to 12% of severe preeclampsia cases. Differentiating HELLP syndrome from other conditions like thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, HUS, and disseminated intravascular coagulation, DIC, can be challenging. Elevated platelet-associated immunoglobulin indicates immune involvement. Low-dose aspirin therapy has been explored for prevention, providing a 15% risk reduction. Treatment involves delivery of the infant whenever possible, with thrombocytopenia usually resolving post-delivery. In cases where immediate delivery is not feasible, bed rest and aggressive hypertension treatment may help increase platelet counts. Considering other causes of thrombocytopenia during pregnancy, immune thrombocytopenia, ITP, is a common disorder in women of childbearing age. ITP should be considered when assessing thrombocytopenia in pregnant women, although maternal autoantibody levels do not necessarily predict fetal platelet count. HIV infection, systemic lupus erythematosus, and antiphospholipid syndromes are potential contributors to thrombocytopenia during pregnancy. Now, let's shift our focus to thrombotic thrombocytopenic purpura, TTP, a condition with a unique set of characteristics. TTP is characterized by a triad of microangiopathic hemolytic anemia, thrombocytopenia, and neurologic abnormalities. It often presents with fever and renal dysfunction, forming a pentad of symptoms. In addition to the triad, individuals with TTP may experience symptoms such as diarrhea, anorexia, nausea, weakness, and fatigue. While uncommon, TTP is not rare and may be on the rise. It affects about twice as many women as men, primarily in the age range of 30 to 40 years. Interestingly, approximately 50% of patients develop TTP after a viral-like illness. Thrombotic thrombocytopenic purpura, TTP, manifests in various forms, each with unique characteristics. Let's explore them. 1. Acute episode. Most patients experience a single acute episode. A small fraction may have recurrent episodes at seemingly random intervals. 2. Recurrent TTP, occurs in 11% to 28% of TTP patients, leading to repeated episodes with varying frequency. 3. Drug-induced TTP, linked to purinoreceptor blocking agents like ticlopidine and clopidogrel. Ticlopidine causes TTP in about 0.025% of patients, while clopidogrel-induced TTP is approximately 4 times less frequent. 4. Chronic relapsing TTP, a rare form with episodes occurring every 3 months from infancy. Deposits of hyaline thrombi in end arterioles and capillaries composed of platelets and von Willebrand factor, VWF. Microvascular platelet aggregation leads to thrombi formation, causing organ ischemia due to the occlusion of blood flow. Neurologic manifestations range from headaches to coma, highlighting the severity and impact on the central nervous system. Renal dysfunction is common, indicated by proteinuria and hematuria, reflecting the involvement of the kidneys. Gastrointestinal bleeding is frequent in severely thrombocytopenic patients, occasionally causing abdominal pain due to mesenteric microcirculation occlusion. Now, let's explore the laboratory findings associated with TTP. Peripheral blood film shows decreased platelets, RBC polychromasia, and RBC fragmentation, providing crucial diagnostic insights. Evidence of intravascular hemolysis includes reduced haptoglobin, hemoglobinuria, hemosideronuria, increased serum unconjugated bilirubin, and elevated lactate dehydrogenase activity. Bone marrow examination reveals erythroid hyperplasia and a normal to increased number of megakaryocytes, aiding in confirming the diagnosis. Distinguishing from DIC, key coagulation tests such as partial thromboplastin time, prothrombin time, fibrinogen, fibrin degradation products, and D-dimer are usually normal, aiding in differentiation from disseminated intravascular coagulation, DIC. Let's delve into the intricate relationship between ADAMTS13 and ultra-large von Willebrand factor, ULVWF, multimers in the development of thrombotic thrombocytopenic purpura, TTP. Endothelial cells and megakaryocytes play a pivotal role in generating larger ULVWF multimers than those found in plasma. These ULVWF multimers exhibit exceptional effectiveness in binding platelet complexes under fluid shear stresses. The cleavage process is facilitated by ADAMTS13, a protease responsible for swiftly cleaving ULVWF multimers into smaller, normal von Willebrand factor, VWF, multimers. ADAMTS13 demonstrates heightened efficiency under high shear stress, particularly when VWF multimers are partially unfolded. Now, let's explore the familial chronic relapsing form of TTP, characterized by recurrent thrombocytopenic episodes with or without organ damage. This form exhibits a complete deficiency of the VWF cleaving metalloprotease. The common form of TTP, usually nonfamilial and lacking recurrence, presents patients with metalloprotease deficiency. This deficiency results from the removal or blockade of the enzyme by an autoantibody present during TTP but disappearing in remission. The ADAMTS13 assay is a diagnostic tool that measures the VWF cleaving enzyme. However, results take days, necessitating prompt treatment decisions. The assay has limited sensitivity and specificity for TTP, prompting ongoing development of additional tests for ADAMTS13 and TTP with a focus on achieving rapid and accurate diagnosis. ULVWF multimers are typically present at the onset of a TTP episode in the plasma. They, along with normal-sized plasma multimers, diminish as TTP progresses and thrombocytopenia worsens. If the patient survives TTP without relapse, plasma VWF multimers usually return to normal. Persistent presence of ULVWF multimers after recovery signals a likelihood of recurrent TTP episodes, especially in early childhood or infancy. The most effective treatment involves plasma exchange using fresh frozen plasma or cryoprecipitate poor plasma, yielding rapid and dramatic effects within a few hours. If plasmapheresis is unavailable, immediate administration of corticosteroids and fresh frozen plasma infusions is crucial. Swift arrangements for plasma exchange should be made. Plasma exchange has a dual effectiveness, removing some ULVWF multimers through apheresis and supplying deficient protease in plasma to aid in degrading ULVWF multimers in the patient's blood. Despite some cases recovering with corticosteroids alone, high-dose corticosteroids are recommended alongside plasma exchange. The typical duration of plasma exchange is 5 days. If no response within 5 days or worsening condition, consider additional interventions such as vincristine, azathioprine, splenectomy, or passing patient's plasma over a staphylococcal A column to remove immune complexes. The use of antiplatelet agents, prostacyclin, heparin, or fibrinolytic agents is debated and lacks clear evidence of efficacy. Platelet transfusions should be avoided unless severe hemorrhagic issues arise. Before 1990, TTP had a mortality rate exceeding 80%. With rapid diagnosis and exchange plasmapheresis, 80% of early treated patients now survive. Regular monitoring of platelet counts is essential due to known relapse occurrences. Detection of ULVWF multimers in patient samples after complete remission accurately predicts relapse in 90% of cases, offering promise for long-term TTP management. Hemolytic uremic syndrome, HUS clinical resemblance to TTP. Clinically similar to TTP but predominantly found in children aged 6 months to 4 years. It is a self-limiting condition. About 90% of cases linked to Shigella dysentery or enterohemorrhagic Escherichia coli, E. coli, OH serotypes, especially O157, H7. These organisms can often be cultured from stool samples. Bloody diarrhea in childhood HUS caused by colonizing the large intestine with the offending organism, leading to erosive damage. Shiga toxin from S. dysentery or Shiga-like toxins, SLT1 or SLT2, from enterohemorrhagic E. coli. Toxins attach to renal glomerular capillary endothelial cells, causing damage, release of ULVWF multimers, and hyaline thrombi formation. Results in renal failure, thrombocytopenia, and microangiopathic hemolytic anemia. RBC fragmentation in HUS usually less severe than in TTP. Renal dialysis may be required for more severe cases in children. Lower mortality rate in children compared to TTP, but residual renal dysfunction can occur. Adult form often associated with exposure to immunosuppressive or chemotherapeutic agents, or postpartum. Symptoms may appear weeks or months after exposure. Renal impairment in adults more severe, often requiring dialysis. Cause unclear but may involve the development of autoantibodies to endothelial cells. Outbreaks linked to E. coli contaminated water affecting both children and adults. Cardinal signs include hemolytic anemia, renal failure, and mild to moderate thrombocytopenia. Lack of neurologic symptoms, presence of renal dysfunction, and absence of other organ involvement suggest HUS. Thrombocytopenia tends to be mild to moderate in HUS, primarily in kidneys, whereas TTP usually has severe thrombocytopenia. Anemia and RBC fragmentation are milder in HUS, mainly occurring in the kidneys. In ambiguous cases, treating as TTP is prudent. Disseminated intravascular coagulation, DIC activation of coagulation cascade. Common cause of destructive thrombocytopenia. Coagulation cascade activation, triggered by various agents or conditions, leads to consumptive coagulopathy. Result, platelets trapped in intravascular fibrin clots. Similarities to TTP, including microangiopathic hemolytic anemia and thrombi deposition in arterial circulation of multiple organs. Differentiation, in DIC, thrombi primarily composed of platelets and fibrinogen, while TTP thrombi consist mainly of platelets and VWF. Acute DIC, rapid platelet consumption, severe thrombocytopenia, decreased factor V, factor VIII, and fibrinogen levels. Positive D-dimer test, indicating in vivo thrombin generation. Life-threatening, requires immediate treatment. Chronic DIC, ongoing, low-grade consumptive coagulopathy. Clotting factors may be slightly reduced or normal, compensatory thrombocytopoiesis results in moderately low to normal platelet count. D-dimer may be undetectable or slightly to moderately increased. Generally not life-threatening, treatment not urgent. Often associated with an underlying condition, resolving the underlying condition usually resolves chronic DIC. Drug-induced thrombocytopenia, direct interaction with platelets. Some drugs directly interact with platelets, leading to thrombocytopenia. Examples, ristocetin, no longer in use, facilitates VWF interaction with platelet membrane, causing in vivo platelet agglutination and thrombocytopenia. Hematin, used for acute intermittent porphyria treatment, causes transient thrombocytopenia, possibly by stimulating platelet secretion and aggregation. Protamine sulfate and bleomycin may induce thrombocytopenia through a similar mechanism. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.